Never agree to this. 5. Deadly surgeries for seniors. It is a common misconception that when a surgeon recommends an operation, it is automatically the best course of action. The prevailing thought is that the doctor possesses superior knowledge, the hospital is equipped with the necessary tools, and all the logistical arrangements are in place, leaving the patient with little to do but sign the consent forms. This deeply ingrained belief in medical authority is something I, too, once shared. However, my perspective underwent a profound transformation as I began to meticulously track the outcomes of patients who underwent what were considered routine procedures. The stark reality I observed was that many did not emerge better, but were, in fact, permanently altered. I witnessed individuals who entered the hospital seeking relief from back pain, only to leave with an inability to walk at all. Another patient who successfully navigated open-heart surgery endured 6 months of debilitating complications that had never been disclosed. This experience illuminated a critical, often unspoken, truth. As the human body ages, its ability to withstand the rigors of surgery diminishes. It's not just the underlying condition that poses a challenge, but the surgical intervention itself. My name is Dr. Kevin Adewale, and I am a cardiothoracic surgeon with over 2 decades of experience in the operating room. Today, I intend to shed light on 5 surgical procedures that, for individuals over the age of 60, carry significant, often hidden, risks. Consider this analogy. If you subject a brand new car and a car with 200,000 miles to the same rigorous stress test, would you expect identical results? The answer is unequivocally no. Yet, for an extended period, medical practice treated a 70-year-old body with the same protocols and recovery expectations as a 40-year-old one. While this approach is gradually evolving, the pace of change is far too slow. Let's delve into what transpires within an aging body under general anesthesia. The heart is forced to exert greater effort, the lungs require more time to fully clear the anesthetic agents, and the kidneys experience a reduction in their capacity to metabolize medications. Perhaps most surprisingly, the brain undergoes temporary disorientation, a condition known as postoperative cognitive dysfunction, which can persist for weeks or even months. This phenomenon occurs with alarming frequency in patients over 70, a fact that is frequently understated. It is crucial to emphasize that age alone is not an absolute contraindication for surgery. I have operated on 80-year-olds who recovered more swiftly than some individuals in their 50s. Age is merely a numerical designation, but frailty is a distinct medical concern. Frailty signifies that the body's resilience has fallen below a critical threshold, a state observed in approximately 40% of individuals over 75, and this figure escalates to nearly 60% for those over 85. Therefore, the paramount question is not solely whether a patient can survive the surgery itself, but rather whether they possess the capacity to endure and recover from it. These are 2 fundamentally different considerations, and this distinction holds immense weight, particularly in the current medical landscape. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass. Grafting, or CABG, stands as one of the most prevalent major surgical interventions for older adults. The fundamental principle is straightforward: to bypass blocked arteries and restore blood flow. While exceptionally effective for suitable candidates, the reality of the procedure is far more demanding than typically depicted. Open heart surgery necessitates the complete cessation of cardiac function. During this period, patients are placed on a cardiopulmonary bypass machine, a device that assumes the roles of the heart and lungs, enabling surgeons to operate. For a 60-year-old in robust health, this maneuver is generally manageable. However, for a 78-year-old with underlying conditions such as kidney disease, mild diabetes, and existing cognitive decline, the bypass machine represents a formidable assault on every organ system concurrently. Medical studies indicate that in frail elderly patients, open heart surgery carries a substantial complication rate, ranging from 30% to 40%. These complications can include stroke, kidney failure, prolonged confusion, and extended reliance on a ventilator. A particularly sobering statistic is that up to 15% of high-risk elderly patients undergoing this procedure do not survive the initial 30 days post-surgery. Fortunately, for many individuals, an alternative now exists: transcatheter aortic valve implantation, or TAVI. This catheter-based procedure bypasses the need to stop the heart or open the chest, offering a less invasive yet highly effective treatment option. This does not imply that individuals should automatically refuse heart surgery, but rather underscores the importance of inquiring about less invasive alternatives. Asking this single question can fundamentally alter a patient's treatment trajectory. Surgery number 2: aggressive spinal surgery. Back pain is an almost universal complaint among individuals in their 60s and 70s. Indeed, it's rare to encounter a patient over 70 who hasn't expressed concerns about their back. Increasingly, spinal surgery, encompassing fusions and multi-level decompressions with the insertion of hardware, is presented as a solution. It is imperative to understand that certain spinal surgeries are indeed critical, particularly when there is active compression of the spinal cord, leading to loss of bladder control or paralysis, which demands immediate surgical intervention. However, the efficacy of elective spinal fusion for chronic back pain in elderly patients is a subject of significant concern. A landmark study published in the journal Spine revealed that among patients over 65, complex spinal fusion procedures exhibited a complication rate exceeding 40%. These were not minor issues. They included blood clots, infections, hardware failure, and adjacent segment disease. This latter condition arises when the vertebrae above and below the fused segment begin to degenerate due to the permanent alteration in spinal mechanics, as the rigid hardware forces the rest of the spine to absorb increased stress. What is particularly frustrating is the often disappointing pain relief. Research demonstrates that for many elderly patients with degenerative spine disease, aggressive surgery offers no superior long-term pain relief compared to physical therapy and targeted injections, but with a dramatically higher risk profile. A respected colleague, a brilliant spine surgeon, once shared a profound insight. "Kevin, sometimes the best operation is the one you don't do." This statement resonates deeply with me. If you have ever been told that surgery was your sole recourse for back pain, please share your experience in the comments. Knowing how many have heard these exact words would be invaluable. Surgery number 3: major cancer resections. This topic is perhaps the most emotionally challenging, as the word cancer often triggers an immediate and powerful instinct to cut it out and eradicate it. I empathize with this sentiment completely, as I would likely feel the same way. However, 2 decades of surgical experience have taught me a crucial lesson. The ultimate goal of treatment is not merely the removal of a tumor, but the extension of a patient's quality of life and the provision of more years of well-being. In some instances, particularly with frail elderly patients, extensive surgery can inadvertently have the opposite effect. Consider, for example, the Whipple procedure for pancreatic cancer, one of the most complex operations in modern medicine. This surgery involves the removal of the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. It is a lengthy procedure, often lasting 6 to 10 hours. While it can be life-saving for younger, healthier individuals, its outcome in an 80-year-old with pre-existing heart disease and compromised kidney function can be tragic. The surgery may be technically successful, the tumor removed, but the patient may succumb within weeks, not to the cancer itself, but to the overwhelming complications of the operation. This is termed futile surgery, and its prevalence is higher than many are willing to acknowledge. A seminal study by the American College of Surgeons indicated that nearly 1 in 5 elderly cancer patients undergoing major resection experienced failure to rescue, meaning a complication arose that their weakened bodies could not overcome. Therefore, a crucial conversation to have with your oncologist is, if we do not proceed with surgery, what are the implications of watchful waiting, radiation therapy, or targeted therapy for someone of my age and health status? This question can open doors to treatment pathways that patients may not have even realized existed, and sometimes these alternatives prove to be genuinely superior. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are undeniably among the most successful surgical innovations capable of dramatically improving a patient's quality of life, transforming them from individuals with limited mobility to active participants in their families' lives. However, the decision-making process becomes considerably more nuanced for older adults. The term elective signifies that the surgery is not an emergency, affording patients time for careful consideration, preparation, and, most importantly, a thorough assessment of whether it is the opportune moment for their specific physical condition. Statistics reveal that for patients over 75 with 3 or more significant health issues, such as heart disease, diabetes, chronic kidney disease, or obesity, elective joint replacement carries a substantially elevated risk of perioperative complications. Blood clots, particularly deep vein thrombosis, pose a significant danger with the potential to travel to the lungs and cause life-threatening pulmonary embolisms. In older patients with compromised circulation, this risk is markedly higher than in younger individuals. Add to this the increased likelihood of postoperative pneumonia due to prolonged immobility and the potential for hospital-acquired infections, and the risk profile becomes considerably more complex. It is essential to clarify that this does not suggest that individuals should forego joint replacement altogether. Rather, the pertinent question is whether their body is currently in the optimal state to undergo such a procedure. Optimizing blood pressure, blood sugar levels, weight, and cardiovascular health prior to elective surgery can significantly mitigate complication rates. A growing trend in some hospitals involves mandatory prehabilitation programs for high-risk elderly patients scheduled for these operations, a practice that represents a prudent and beneficial approach. Has a doctor ever discussed prehabilitation with you prior to a planned surgery? The concept is unfamiliar to many, yet it is a vital consideration. Surgery number 5, emergency abdominal surgery. This category presents a unique challenge because, unlike the preceding procedures, emergency abdominal surgery is not a choice. It is a sudden and urgent necessity, often arising from conditions like a perforated bowel, a ruptured appendix, or internal bleeding. These critical situations do not allow for measured discussions. However, understanding the potential risks in advance before an emergency arises can significantly influence family decision-making during those incredibly stressful moments. Emergency abdominal surgery in patients over 75 is associated with some of the highest mortality rates across all surgical disciplines, reaching 30% to 50% in the most severe cases. This is not a reflection of surgical skill, but rather the overwhelming burden placed on an aging body subjected to sudden trauma. Multiple organ systems, including the liver, kidneys, heart, and lungs, are simultaneously impacted. The inflammatory response that a younger body can effectively manage within days can escalate in an older individual into systemic inflammatory response syndrome, leading to sequential organ failure, a dire and challenging medical scenario. So, what practical steps can you take with this knowledge? There are 2 key actions. Firstly, never ignore persistent abdominal symptoms such as pain, bloating, or changes in bowel habits, especially if you are over 60. Prompt medical attention is crucial, as early detection often leads to less invasive and more effective treatment, preventing the situation from escalating into an emergency. This proactive habit can profoundly alter outcomes. Secondly, engage in conversations with your family now, not in the sterile environment of a hospital corridor at midnight, about your wishes should emergency surgery become the only option. Discuss what constitutes an acceptable quality of life for you. These discussions, while perhaps uncomfortable, are not morbid. They are an act of profound love and preparedness for those who will be making critical decisions on your behalf. Having examined these 5 surgical categories, let us now consolidate this knowledge into actionable strategies. Information devoid of action can breed anxiety, a feeling I am keen to help you avoid. Prior to any significant planned or recommended surgery, every patient over 60 should pose 4 critical questions. First, what are the consequences if I do not undergo this surgery? A competent surgeon will provide a candid response. If the prognosis indicates no urgent changes within the next 6 to 12 months, you gain invaluable time for reflection, seeking a second opinion, and optimizing your health. Second, are there any less invasive alternatives available? Medical advancements over the past 15 years have been extraordinary, with robotic surgery, endoscopic procedures, and catheter-based interventions now commonplace in most major hospitals. Third, what does the recovery process realistically entail for someone of my age and health profile? This question requires a specific, personalized answer, taking into account your individual health status, current medications, and living situation rather than a generic response. Fourth, and perhaps the most crucial question that many overlook, what is your personal complication rate for this specific procedure in patients over 70? Surgeons meticulously track these metrics. A confident and transparent surgeon will readily share this data. Any hesitation or discomfort in answering this question should be considered significant information in itself. Before concluding, I wish to offer a message of hope. This discussion is not intended to instill fear, but rather to empower you with knowledge of your options, which have never been more potent than they are today. Minimally invasive surgical techniques have revolutionized possibilities for elderly patients. Laparoscopic procedures, utilizing small incisions and camera guidance, drastically reduce recovery times. Robot-assisted surgery allows for a level of precision unattainable by human hands alone. Catheter-based cardiac interventions have opened doors for patients who would have been deemed inoperable under traditional surgical approaches. Beyond surgical interventions, optimized medical management plays a vital role. The judicious combination of medications, supervised physical therapy, targeted injections, and nutritional support can effectively manage numerous conditions that historically might have necessitated surgery. The body possesses an innate capacity for healing, and sometimes the most beneficial role a surgeon can play is to facilitate this process by providing the necessary tools. Allow me to share the story of a patient I'll call Gerald. At 71, a retired engineer with a remarkably sharp intellect, Gerald was advised by 3 different surgeons to undergo open-heart surgery for a blocked coronary artery. Each recommendation was the same. Gerald wasn't apprehensive about surgery itself, but rather about the potential loss of his cognitive faculties. He had witnessed his wife's arduous recovery from a major operation 2 years prior, an experience that left her disoriented, exhausted, and fundamentally changed. He confided in me. Dr. Adewale, she went in as my wife and came out as someone I had to care for. That poignant statement has remained with me. Upon a thorough review of Gerald's complete medical profile, including his kidney function, frailty score, and cognitive baseline, I dedicated 40 minutes, not the standard 15, to a comprehensive discussion. I presented him with the truth. While surgery was an option, so was an aggressive medication regimen coupled with cardiac rehabilitation. The data specific to his profile indicated comparable 5-year outcomes between both approaches. Gerald opted for the non-surgical path. 4 years later, he sent me a photograph. He was standing atop a hiking trail in Colorado with his 2 granddaughters, both now taller than him, his face beaming with joy. This is the most critical takeaway. A surgical recommendation is not a final judgment. It is the commencement of a dialogue. You are not a passive recipient of medical directives. You are an active participant in your own healthcare journey. From the moment you enter a surgeon's office, you possess the unequivocal right to ask every challenging question, to explore all available alternatives, and to take all the time you deem necessary. While the surgeon wields the scalpel, the ultimate choice rests with you. And that choice, made with complete information and a clear understanding, is the most potent tool in medicine, exceeding the power of any surgical procedure I have ever performed. To summarize, we have discussed 5 surgical interventions that present significant, often overlooked risks for individuals over the age of 60. Open heart surgery in frail patients, where less invasive alternatives are increasingly available. Aggressive spinal fusions, where the evidence supporting long-term pain relief is often less compelling than patients are led to believe. Major cancer resections, where the paramount objective must always be to maximize quality of life and extend well-being. Elective joint replacements in severely ill patients, where the timing and preparation are as critical as the surgery itself. And emergency abdominal surgery, where early detection of symptoms and open family discussions are the most effective forms of protection. It is imperative to reiterate that this information is not an advocacy for avoiding all surgery. Surgery saves lives every single day, a reality I have witnessed and actively participated in, a field of medicine in which I take immense pride. The fundamental message is this: be an informed patient. Ask the difficult questions. Inquire about all available alternatives. Seek a second opinion, and, if necessary, a third. Your age is not a deficit. It is a factor to be considered in a comprehensive treatment plan. What question would you most want to ask your surgeon before undergoing a major operation? Share your thoughts in the comments section. I review every single one. If this video has provided clarity or assisted you or a loved one in approaching a surgical decision with greater insight, please share it. That single act of sharing might be the most impactful contribution you make today. Prioritize your well-being, maintain your curiosity, and continue to be an advocate for your own health. You deserve a surgeon who provides thorough explanations and a medical team that regards you as a valued partner in your care. Finally, please remember that the information presented here is general medical knowledge derived from published research and clinical experience. Every individual's situation is unique. Before making any decisions regarding surgery or treatment, it is essential to have a complete and honest conversation with your own physician or specialist who possesses the most comprehensive understanding of your medical history and your body's specific needs. That informed, direct, and unhurried conversation is indeed the very foundation of effective medicine.